I am Dr. Barry Bultz, Professor of the Division of Psychosocial Oncology and Head of the Division of Psychosocial Oncology in the Department of Oncology at the Cumming School of Medicine at the University of Calgary. I also hold the Daniel Family Leadership Chair in Psychosocial Oncology. Screening for distress is really a tool to help guide the clinical interview, to help improve patient-physician communication, the healthcare team's communication with the patient and what those key issues are. And we're providing metrics, in this case the use of the ESAS and the Canadian Problem Checklist, an opportunity for the team to clearly zone in on what are the most frequently reported problems. Once we do that, I think we're opening up an opportunity for a conversation on how we can help facilitate better patient outcomes, better improvement in terms of quality of life, and helping the patient live with their cancer experience in a way that they know that they're not alone and very much part of the team. Screening is not the real challenge. The real challenge is around how we're going to deal with the symptoms that are identified through screening for distress, and that continues to be a challenge. What we have is a very siloed approach to delivery of health services, specifically in cancer care in our situation. But I do believe that what this is at least beginning to share with our patients and the healthcare community around what those key concerns are. Getting the medical team that are so focused on treatment and cure to address the patient experience will be another challenge, and I think that yet has to be determined. Although we're beginning to see promising outcomes in a number of provinces in this country, and I think we're very fortunate here in Canada to receive so much support in terms of a national rollout. As well, in Canada at least, screening for distress as a sixth vital sign has been an accreditation standard since 2009, again reaffirmed in 2016. So I think we're on the right track, but it takes a long time to change the culture of practice. Within the cancer programs and all cancer programs, we are so accustomed to focusing on our area of specialization and rely on clinical acumen, expert intuition to perceive what the patient's experience is. We are providing through screening for distress, now called a number of different titles, putting patient first, the metrics behind what the patients are actually experiencing, and in a way empowering the patient, and we should be empowering the healthcare team to look at the outcomes of the patient's reported measures on screening for distress. The real challenge is creating that buy-in so that screening can take place within each and every cancer center and for each and every patient at the point of entry, at significant time points during the cancer journey, certainly at the initiation of treatment and at the completion of treatment, and on an ongoing basis after that. I also think that the opportunity lies ahead of us in terms of getting primary care to initiate screening for distress as a strategy to approaching patients.